Beautiful. Welcome to week 7, term 1 of our SPAAM seminar series. Today we have 2 speakers. First we'll be hearing from Byron, talking about an optimal control theory formulation that's based on maximizing the life expectancy of cancer chemotherapy patients. Over to you, Byron.
Okay, so for those who haven't heard any of my talks before, I'm Byron, and my research area is on applying optimal control theory in cancer chemotherapy. So just a brief introduction. We have nice mathematical models that can tell us about disease progression, and we can also use these models to do like in silico chemotherapy trials. So these are computational simulations of different drug regimens, and then we compare them in terms of different therapeutic indexes. However, there is a disadvantage, and this disadvantage is that we can only test a handful of drug regimens. So this motivates the use of mathematical optimization, such as optimal control theory, in order to determine drug regimens that optimize some therapeutic index. So a key challenge in the field is how to create objective functions that can balance the 2 competing objectives of, on the one hand, eliminating the tumor, but on the other hand, retaining low levels of drug toxicity to make the treatment sustainable. And so a standard approach that has been used in the literature is to minimize this objective function here that comprises of 2 terms. So the first term, phi here, depends on the size of the tumor at the end of the therapy. And the second term is an integral term that depends on the quantity of the drug administered. So the disadvantage here is that this parameter R that weights these 2 competing objectives is arbitrary. And so, of course, you can do a sensitivity analysis and test different optimal solutions. However, the parameter R is not biologically tractable. And it always depends on what the objective of the practitioner is. In previous works, what we did is we maximized the life expectancy of the patient under different therapy outcomes. So this idea basically is, if we maximize the life expectancy of the patient, we balance nicely drug toxicity and reducing the size of the tumor, because if not, the life expectancy would be small. So the general framework that we use has this form here, where Li is the expected lifespan of the patient given that an outcome I has occurred. Pi is the probability of the outcome I occurring, and this is a functional of the size of the tumor N, and also on the drug quantity administered Q. So the optimization problem was to maximize J, so find the drug regimen Q, which is a function of time, that maximizes J, subject to nonlinear tumor growth models. And so there was a disadvantage here, and the disadvantage was that the life expectancies at I were chosen a priori. So now I will present you a new approach that we used in order to have a functional forms for the life expectancy under specific outcomes. So this potentially could have parameters that could be evaluated by data at some future work. So the outline of my talk is the following. First, I will give a very brief description of the model. I won't go through details, just to get the general idea. Then I will present some of our results. And lastly, if time permits, I will summarize. So first, we consider an individual of a certain age, and we consider that this individual suffers from a curable cancer. So we consider 2 outcomes. The first outcome is cure, and the second outcome is that the therapy fails to cure. So then we consider also different mortality events. So a patient can die due to his or her or their age. So as a member of a general population, there is a specific probability of death. Then we have tumor-related mortality, because of course the patient dies from the tumor. And last we have drug-related mortality, so the patient can die from the drug. So we incorporated these events by using a Poisson process. So here we have the probability of an individual dying at a certain time t. We also we will use later this random variable tau that tells us when the tumor has been eliminated, in the case where the tumor gets eliminated. And to evaluate the probability of the tumor getting eliminated, we use what we call the tumor control probability, or TCP. That is a function of time and tells us the probability of the tumor to get eliminated by some time point t. Okay, I will go briefly. I won't emphasize on this point. But assume that we take the first case where the tumor has been eliminated. So we assume that it gets eliminated at some random time point tau. So then the life expectancy of the patient is given by this form. Here we have separated it into two terms. The first term is prior tumor elimination, where the tumor size is positive. And the second is post-tumor elimination, where we have 0 for the tumor size. And then we have weighted under these two different outcomes that we have considered. So the first term here is in the case where the tumor hasn't been eliminated, and the life expectancy is given by this term here, noted in red. And the second term here is under the outcome that the tumor has already been eliminated at some time point tau. And because tau is a random variable, as we mentioned before, we take the expectation on tau for this last term. And okay, this is a detail. Here is a PDF of tau. So here we will present some of our results. So what we found was that our optimal solutions are what we call treat and stop. So this means that the maximum dose of the drug is administered until some time point t, and after this time point, no drug is administered. So if we look, for example, in panel B here, the red bar shows the drug administration. So we administer the maximum that is scaled to 1 until around 30 days, and then drug administration stop. Now, if we look at the blue line is the probability of the tumor getting eliminated, the tumor control probability. So we can see that after the treatment, it's around 90% the tumor gets eliminated. And so now to indicate the survival probabilities, the black dashed line is the survival probability for an average individual of the age of the patient. The dashed pink line is the survival probability in the case where the tumor gets eliminated. So after the treatment, we can see that it remains constant, and it's around a bit less than 50%. And the continuous black line is the probability where if the tumor hasn't been eliminated, the probability of survival. And we can see that it decreases with time. So we can better understand it if we make an experiment in our mind where there's a clinical trial and there are patients where the tumor hasn't been eliminated. We will have, as the time passes, we will have a larger number of people who have died from the treatment, and eventually we will have 0 patients alive. And so panel B shows basically the same thing, but for a different age group. Here we have 60 years old, here we have 95 years old, and we can see that the survival probability of an average individual in the population slightly decreases with time. Okay, so here we've seen how the optimal control regimens relates to the survival probabilities. So at this point, we compare treat and stop drug administration regimens with the optimal drug administration. So I remind that treat and stop is we administer the maximum dose until a certain time, and then we stop drug administration. So here in the horizontal axis, we have the drug administration period. In panel A, we show the survival probabilities as well as the tumor control probability. Whereas in panel B, we show the life expectancy of the patients under different drug regimens here. So first, what we can see is, so here the dashed red line showcases the optimal drug administration period. So if we administer drug for longer than this period, we can see that the blue line, the tumor control probability, is almost equal to 1. So the dominant outcome is the outcome where the tumor has been eliminated. And if we look at the probability of survival in the case where the tumor gets eliminated, so this is the pink line, we can see that it steadily decreases. So this shows that if we administer drug for more than the optimum period, the primary mortality is due to excessive drug administration. And in fact, what's interesting is that if we look for longer than around 44 days, we can see that the probability of survival is independent of the outcome. So here's a continuous black line is in the case where the tumor hasn't been eliminated. Now, if we look for drug administration periods that are shorter than the optimal drug administration period, we have two cases. The first case is between 0 and around 22 days, where basically the tumor control probability is 0. So in that case, the survival probability is less than 0.1. So this is quite suboptimal. And in the case where we have in between 24 and the optimal drug administration regimen, we can see that the tumor control probability is notably less than the tumor control probability in the optimal case. So there is a notable probability of the tumor not getting eliminated. And in that case, if you look at the life expectancy would be smaller than a year. So this makes the treatment suboptimal. So here we can see that our objective function nicely balances these two objectives in terms of survival probabilities. And then another thing that we did is that we compared different optimal drug regimens in terms of initial tumor size, also in terms of the susceptibility of the patient to the drug, and in terms of the patient's age. So I won't go through details in the slides. All I will say is that we found that the age didn't affect significantly the optimal regimen, nor the outcome of the treatment. And so then we looked in more detail in terms of initial tumor size and the patient's susceptibility to the drug. So all these axes, the horizontal axis is the initial tumor size logged in base 10, and the vertical axis is how do you say? Cannot find the word. How well the patient reacts to the drug side effects. So it's more like the endurance of the patient to the drug. And we can see that what's interesting is that patients can be subdivided into treatable and untreatable categories. So if you look at panel A, where the color coding relates to the optimal drug administration period, the white region is people that cannot benefit from the treatment. So the optimal administration period would be no drug at all. And we can see that there is a threshold value for the person's resilience to the drug, where that separates treatable and untreatable patients. So the optimal drug administration jumps from 0 drug to a positive value that spans from 15 to around 35 days. And the value of the jump depends on the initial tumor size. So the larger the initial tumor size, the larger the drug administration. Now, if we look at the cure probability, so this we have defined by the tumor control probability multiplied by the probability of the patient surviving drug administration, we can see that in the boundary, the cure probability is very small. So it's around 0. And to be more precise, we can look at in the drug-induced death probability, so the probability of the patient dying from the drug, which is very large. It's around larger than 0.8. So this means that our optimal solutions basically prioritize over eliminating the tumor, opposed to limiting drug toxicity for this group of patients. So this sounds a bit counterintuitive, but we can look more in detail And we can see that the life expectancy of a patient, in the case where the patient is untreated, is smaller than 3 months. Whereas in the case where the patient is treated, it's quite large. So it can take, for example, 10% of the life expectancy of an average individual in the population. So what the optimal control framework does, it says that I'm willing to take the risk in order to increase the life expectancy of the patient. So what we want to do next to correct this issue is we want to take into account biological mechanisms of drug-induced toxicity. So I can go through more details after the talk. I don't know if I'm out of time or we've got a few more minutes. So yeah, okay. One of the primary toxicities is damage in the bone marrow. So when you excessive chemotherapy treatment can damage the bone marrow, and the patient would have less amount of white blood cells in their blood. So as a consequence, usually the treatment would stop for the patient to recover, and this would result in an increase in the tumor size. So we can incorporate this by using a hematopoietic model. So this is what we're thinking to do next. So here, just to summarize what we have done, we have maximized the expected lifespan of a patient that is weighted over different future outcomes. So we employed what we call the tumor control probability to model the probability of the tumor getting eliminated. And we also use Boston processes to express mortality rates of the patients. So in terms of our results, we found that this nicely balances drug toxicity and reducing the size of the tumor. And this is done in terms of the tumor control probability and the survival probabilities that we have expressed previously. We found that optimal drug administration regimens were independent of the age. And lastly, patients can be subdivided into treatable and an untreatable category. In the untreatable category, however, the optimization framework prioritizes on eliminating the tumor. And our next step is to consider myelosuppression that I explained before in order to better model drug toxicity. So yeah, this is the talk. Thank you for your attention.